Ladies and gentlemen, welcome again to the second session, and we are going to start with the first presentation. These are three presentations in this session. The first presentation is entitled Mycetoma in Mexico. It's by Professor Welsh, who is an emeritus professor, active School of Medicine, and how apt it is, you know, for an emeritus professor to be working in an active like myself. University Hospital in Mexico. Please, Professor.
Thank you, Mr. Chairman. First of all, I want to thank to Professor Magoo, Dr. Fahal, and all the organizing committee, the WHO, for inviting me to be in this wonderful country. This is my first time in Africa, and I'm impressed, really impressed. Thank you for making me part of the history of the transition period. Monterrey, Mexico is located in the northeast of the country, Mexico, and its limits with the United States. Texas is about 200 kilometers from the United States border. It has, this is a university hospital and the medical campus in Monterrey. There is some of the facilities for research of the different type of specialties. We have in our hospital 44 different specialties, residencies for training and as well as PhDs and master's degree programs. The country, as you can be, is located in certain geographic area that is quite in the line where we found mycetomas, 30 degrees north, 15 degrees south. And this is the picture of Mexico, and you can see that it's unknown cases are in white. That means that there are no physicians that are interested in finding them, because we can found mycetomas in the whole country. But my state is the one that marks 274 as a number. And most of the cases are found and described, reported from Mexico City. Mexico has a different type of environments. You can see some, few of them, areas that are semi-desertic, quite similar to some that you have here in Sudan. We have hills, we have cactus of different types, bushes. We have fields with where they harvest different type of fruits and grains and oranges and maize. These are people that work on the fields, their families, and work there, and they are ethnics, belongs to the ethnic groups that in Mexico are about 10% of the population. Now we have in Mexico, the last census was last year, 113 million of population in the country. Here you can see a city nearby where these people work, and in Zacatecas, that is in the center of Mexico, beautiful city that has over 1 million population. You can see other areas that are in the north. We have dunes and desert like you have here, and those girls that you see there their families work on the fields. You can see that are quite different than the ones that we show just before. And the ethnicity of the people is quite different from one place to another. These are some of the different products that are produced in the country, only a few of them. And this is, I'm going to report using some of the data of Dr. Lopez. Dr. Lopez, Ruben Lopez, is the chair of the department, the laboratory in Mexico City in the School of Medicine of the UNAM. And in this paper that he presented in the study group of mycetoma in Mexico, Dr. Lopez Martinez and a few other people interested in this disease collaborated with him. We can see here the mycetoma, the distribution in from one state to another of 3,463 patients. This is data of about 2 years, 3 years ago. You can increase that for 300. That is the average of patients that are seen per year. And Nuevo León, that is my state, is the third of them, with 274 reported there, but we have more than that. Well, what are the occupation of the patients that have the disease? Farmers occupy almost 60%, housewife, factory workers, students, masons, administrative employees, salesmen, cleaning staff, truck driver, professionists, others. Mycetoma, most of cases are in men, but we have an interesting data that in cases caused by actinomadure madure, most cases are seen in women, with 54.9%. What are the type of mycetoma that we see in the country? Actinomycetic mycetoma, 3,379, with the 97.57%. Eumycetic mycetoma, 84, with 2.43 percentage. The agents that we see in Mexico, Nocaria brasiliensis occupy the first place, followed by Actinomadure madure, Streptomyces somaliensis, Nocaria steroides, Pelletieri, Otitidis caviarum, Transvalensis, Nocaria species, Actinomycete, and total 3,378. When you see this Nocaria species, remember that this data is has been gathered for a long period of time, and in some of the cases they say it is a Nocaria, but they didn't found the grain, didn't culture the agent, so for that reason are reported like Nocaria SP. Nowadays we have another type of tools, genetic tools, that we can identify quite well the agent that is causing the disease. The aerobic actinomycetes, can cause different type of diseases: systemic nocariosis, pulmonary nocariosis. They can affect the central nervous system. They can be presented as skin abscesses and causing myositis. These cases that we are going to relate this midday is actinomycetomas. And you can see here that most of them are in the lower extremities, but we have seen it in the upper extremities, in the perineum, in the buttocks, in the neck, and the trunk. And I want to emphasize that most of the cases are located in the lower extremities, but the second place more frequently found is on the trunk. The posterior wall, the anterior wall, thoracic wall is a common place in our country, in my country. Nocaria brasiliensis occupy the first place as a causative agent, and you can see all of them that you can see in the left. We have seen it, with the exception of nocardiopsis dansombile, that we have not seen any case or reported any case. And in the right side, you can see the Nocaria mexicana that recently was published. Nocaria farcinica, we have seen cases. We have not seen cases of Nocaria veterana or Nocaria latina. Here you can see cases of pulmonary nocariosis in which the clinical picture resembles quite much the the picture of tuberculosis, or in our country, in my state, also coccidioidomycosis. We are in the upper zone of the country that is cocci is endemic. The classical form of mycetoma that you already all know, but these are cases that are located on the back, and the dangerous situation in these cases is that they can penetrate, and we have had patients that are paraplegic, ended as paraplegic because of invasion of the spinal cord that unfortunately is in some cases irreversible. These cases, for example, are I published this case several years ago, and we named it the granulomatous type of infection of mycetoma. Here you can see mycetoma of the arm. This area is dangerous because it's very up, and if the disease affects the spinal cord, it could be quite troublesome. The youngest fellow that we have seen is a 3-year-old boy with a mycetoma on his back. And we can see here also on the buttocks. This is in common in some of areas, not so much at present, but still in certain isolated places. They clean after defecating. They can cleanse with some vegetable material, and that can become contaminated with the actinomycete. Mini mycetoma. This term was nominated for first time by Dr. Pedro Lavalle in Mexico in the 60s, when the mini skirt was in fashion. And these are small cases of mycetoma that usually are not very well detected if you don't think in them. The grain of the nocardia in the direct mycological examination, in the tissue, the classical studies in mycocele Saburot, and this is an actinomadure classical grain that was very well described by Dr. Magouv and by the French the people, Maria, Segretan, etc. You can see here the close picture of the grain with the tinctorial characteristics of the grain. Actinomadure is the second in time and in percentage, and we see it from time to time. This case is very interesting because it came in a girl that was 19 years old, that about 5 years before had a hit with a window, and then she developed a small ulceration in the area. We thought that she had dermatofibrosarcoma protuberans and a tumor of fibrotic nature. But when we took the biopsy, we found that she had Streptomyces somaliensis with the classical grain that you can see here, with that separation, and because this type of grain is very hard. And you can see here that this patient that we follow her had involvement of the brain in the anterior lobe, and also the parietal bones and the frontal bones were involved. I sent a letter to Dr. Magouv. That was my first contact with the Sudanese expertise in these cases. Dr. Magouv was at that time the world expert in WHO, and my wife I told her, this woman is going to die. And she said, well, you told me that the dermatologists don't see deaths. The patients don't die. And you better call somebody else, must be an expert in this area, and why you don't write him? So I localized Dr. Magoo's address, and I wrote to him, and he said, this is what we are doing. What are your suggestions? And say, good luck, do what you are doing. I think that you are in the right track. And of course, he was right, because after, you can see here, this patient was lost, as sometimes these patients are. She was placed, after removing the frontal bone, with an acrylic plaque that was removed because the skin was exposed, the plaque was exposed, an ulceration was formed, so it had to be removed. And then the patient was lost. We found her giving a birth in another hospital. We brought her to the hospital, and another operation, taking away the parietal bones, was done. So she was left without parietal bones, and then she had some seizures, and she fell several times to the ground, and she didn't wear any protection on the head. This was something we named that in Spanish milagroso, was a miracle. She didn't hurt herself. And then after she was treated medically, the skull was repaired with her own ribs. So this is a unique case. This is another unique case because it came early in the 70s, more or less in 1971 when I saw him. It was a boy that started when he was 13 years old, and you can find what he had, an infection by Actinomadura pelletieri that is quite rare in Mexico. And then here is when you can see the graphic form for the students, how the grains are, the two varieties, the eumycotic and the actinomycotic type. And the eumycotic, the most frequent, as Dr. Magoo said, is Madurella mycetomatis. And you can see here the one patient that had a recurrence after that one of her fingers was removed, and the patient had a recurrence after surgery in another place. These are the agents of the Mycetoma that we see more frequently in Mexico: Madurella mycetomatis, Madurella grigia, Pseudosporium apiospermum, Fusarium species, and then the others are less common. Pseudosporium apiospermum, Madurella grigia, Madurella mycetomatis, that are common here. A few years ago, when one of my former students, Dr. Salinas, arrived, and one of my students, Dr. Lucio Vera, also before he went to Canada to have his postdoctoral training in infectious diseases, we did some studies in animals. This is in atymic rats. We have also used Balse mice. And here is the picture, a dental picture that we took of the bones that we can see that Nocaria brasiliensis destroys the bones quite easily. When we did this, Dr. Salinas, that was trained in INH, and he's an immunologist, and he came back to Monterrey, to our university. I told him, well, why do you don't start working in mycetoma? And he said, I don't know anything about mycetoma. I said, you don't need to know too much about it. What you have to do is you are a scientist, you are a PhD, so I will tell you my ideas, and you can elaborate on them. Well, he did, and very well. And after a while, Dr. Lucio Vera finished his doctoral thesis on nocardia, and he found two immunodominant antigens that are used in a test that Dr. Salinas developed, in which they use the 26 and 24 kilodaltons proteins for detecting serum levels of patients that are infected with nocardia brasiliensis. This is it was published in Journal of Clinical Microbiology back in 1993. And you can see here that it discriminates quite well among other infections by actinomycetes, tuberculosis, and leprosy. So that is useful for helping detecting the stage of the infection. Well, he has also done studies in cytokines and the protective immunoglobulins against the disease. And I'm going to give you only a few spots of this, because the talk in Monday will be about this schedule of treatment, this form of treatment. You can see patients treated with amikacin, trimethoprim sulfamethoxazole. This patient was paraplegic and was cured with this, but unfortunately he later died of complication because of his paralysis. This is another patient, 3 cycles of treatment. That means 15 weeks of treatment, cured. All the patients are done the usual studies for detecting the agents, and in some rare cases we do also immunological studies. The treatments that are at present available for this, you can see is trimethoprim sulfamethoxazole, amoxicillin clavulanic acid is effective in some cases, amikacin, trimethoprim sulfamethoxazole, netilmycin, trimethoprim sulfamethoxazole, amikacin, trimethoprim sulfamethoxazole, rifampin, amikacin, imipenem or meropenem, moxifloxacin, and linezolid. The Mycetoma treatment, this is what we give to the patients. I'm not going to elaborate about it. And I'm going to give only a few words about our laboratory that I founded in 1998. We named it Interdisciplinary Research Laboratory of the Dermatology Department in our university hospital. This is Dr. Luis Overa. You will find some of, now he's the chair of the laboratory. This is our laboratory. Here are the PhDs that are working with us in PCR and in the mycology and all the different testings for sensitivity, finding new products that can be useful for treating this disease. These are our graduate students, some of them. Of this group, 3 of them have finished her doctoral thesis. And these finally are a group of people that are involved or were involved in the history of mycetoma in Mexico. The first one is Dr. Antonio González Ochoa, who worked very much in the 50s about this disease, and he is practically the father of the mycologists in Mexico. Dr. Latapi, that was the chairman of the Department of Dermatology in Mexico City, in the Instituto Dermatológico Pascua, and with them Dr. Maria, 3 of them dead. But Dr. Maria is a very gentle man, was in Mexico and did a lot of work, field work on mycetoma, and he taught us very much about it. Dr. Rubén López is now the chair of the department, the laboratory of mycology. Dr. Macotela, Ernesto Macotela, he died last year. Dr. Amado González, Dr. Roberto Arenas, Alejandro Bonifaz, Serrano, that is not Mexican, but has spent so much time that we say, well, he's an adoptive Mexican now. Mari Carmen Padilla, the mycologist, Dr. Mayorga in Guadalajara, Dr. Salinas, that is done a lot of studies in immunology. If you look in PubMed, you will find Mycetoma, Dr. Salinas. Well, that is Dr. Salinas. And Dr. Vera, finally myself. Well, this is our group that has been working, Dr. Salinas, Dr. Lucio Vera, and I. Thank you for your attention.
Thank you for your nice presentation. We will have the discussion at the end of this session, so we can discuss all three talks of this session. I'd like now to introduce Professor Verhaal. You already heard him speak earlier this morning, and everybody knows him here because of the institution. Professor Verhaal is going to talk about the mycetoma experience here in Sudan.
Thank you very much, Wendy, for this introduction. This is the White Nile and the Blue Nile. This is the junction between the White and the Blue Nile. Yesterday we have a very nice Nile cruise along the Blue Nile, and I hope everybody will see this junction before going back home. Mycetoma. I'm going to talk about mycetoma as a medical and a social problem here in Sudan. The objective of this presentation, it is to share ideas, experience, and fact on the mycetoma as a serious medical and social problem. And I would like to flag the fact that mycetoma, it is one of the most neglected problems worldwide, to the extent that it is even neglected by many of the international neglected diseases programs, which is a very serious problem. I am going to conclude, for those who not be waiting till the end of the presentation, by saying that mycetoma, it is a thorn in a human flesh. Our job, it is to remove that thorn. As you know, mycetoma, it is a chronic specific granulomatous inflammatory disease. It can be as massive as this. Caused in the Sudan, it is caused either by actinomycetes or by an eomycetes. In the Sudan, the common, it is Madrella mycetomatous, greasy, as sometimes we see them. And for the actinomycetes, the common are Streptomyces sudaniensis, somaliensis, Actinomadura maduri, and rarely we see Actinomadura pelletieri. Nocardia, in the center, we did not come across one of these cases, although Professor Mahjoub saw some of these one case. In the center. All right. Recently, thanks to Professor Goodfellow and his colleagues in Newcastle, now we have Streptomycin sudaniensis. And this is a very clear organism, has a distinct position in this table. There are 3 other organisms coming up, hopefully by the end of this year, hopefully. I don't want to disclose the names of these organisms. Usually they start as a small mass like this, gradually increasing in size, and then the foot or the affected part may assume a shape like this. And then eventually the patient may develop multiple sinuses, and the sinus discharge grains, and the discharge always infected. And this is the black grains coming through the opening of the sinuses. And this is the full-blown picture, a massive, palest, subcutaneous mass with multiple sinuses and a discharge, purulent or purulent, which contains some grains. Although mycetoma, it is a benign chronic inflammatory disease, it has a very malignant behavior. It can be as massive like this, local destruction, recurrence is spread by the lymphatics opened by the blood or the lymphatic tissues, and it will end in a problem like this. Or it can be as massive in a young patient like this, or it can be in the head and neck, and this is a cranial mycetoma, and you can see how this figuring is. And I showed this slide this morning, very miserable situation. She had a mycetoma, actinomycetoma of the foot, she had a bony amputation, and she had it spread along the lymphatics, and she ended in intrapelvic mycetoma infection as well. And you can see in her, tomorrow we're going to see in her MRI how the bladder and the uterus was displaced on the other side. The age distribution, it is, as I mentioned this morning, it is young patients are affected most. This is just to show the trend. Young patient, young active members of society are affected most. You can imagine how miserable these young chaps will be in the future, with a mutating surgery, with recurrence, with destruction and infection, out of the school and loss of education. Most of our patients are males, 3/4 of them. In all age group, males are commonly affected than females. A lot of people assume that outdoor activity is the important cause for the infection. But in areas where mycetoma is common, a lady like this will have a very active outdoor activity, and in some societies, females are more involved than males in outdoor activities. During pregnancy, we notice that these patients develop massive aggressive mycetoma. They have multiple sinuses, massive secondary bacterial infection, increase in the size. We do stop the treatment, but still, I don't think that is the only cause for it. Unfortunately, most of our patients are students, and this is a big problem because this means off school, off education, and all the social consequences of that. What is the cause of mycetoma in Sudan? Is it genetics? Is it immunological? Or is it environmental? Genetics, Wendy is going to talk to us about this. Yes, it can be an environmental cause because the people share the same epidemiological problems, or it can be an immune system. This is Professor Sheikh doing his work for the last 40 years. No infection took place. How is the root of the infection? We don't know really. If we know it, we can have a prevention measurement. This is a very common to see somebody working in the field barefooted. Thorn prick is very common. You can see how massive the thorn is it, and he's using the thorn to remove other thorn at that side. Still, a lot of patients, they don't report on local trauma at the site or a thorn prick at the side of the mycetoma. Really, we don't know how infection can take place. It may be an intermediate host, but really we don't know what is happening here. Incubation period in Sudan is difficult to know because we found in experimental animals, Abdullah Osman and his colleagues in Rotterdam, they managed to introduce the infection in 3 weeks' time with a big, well-developed granuloma. You can see the grains, and this is the full-blown granuloma formation. This is the organism, and this is the grain, and this is the Taiwan tissue reaction around it. Usually the start is slowly growing problem. This patient was seen, he escaped from the clinic, seen 10 years later with a very massive mycetoma in the infraclavicular, supraclavicular, and in the hand as well. So this is one of the problems that patient they present late because it is slow growing problem, and it is painless problem. We notice in some patients they develop local hyperhidrosis, increase in the sweat at the mycetoma site. Really, we don't know the cause. It may be because there is increase in the blood flow in the site, increased temperature locally, and the sweat may be the cause of it. But we notice that when you start to excite this patient, they start to have more sweat. This is the iodine starch test, which is positive on this side. In some patients, Professor Hassan noticed that there is increase in the number of the sweat glands, in the number and in the size, hypertrophy and hyperplasia. Again, one of the important unique features of mycetoma, it is the presence of unilateral varicose veins on the affected site, seen in around 10% of the cases. You can see how massive the mycetoma and how massive the varicose veins on the affected site. We did the venogram in these patients. It was normal. There is no evidence of varicose veins. There is no arteriovenous fistula between this. And histology, Professor Hassan reported that there is increase in the intima and the media of these patients, typical like an arterial appearance at this site. The explanation for this may be that chronic inflammatory reaction. We did angiogram in some of the patients going for amputation. We found there was increase in the circulation at this site. And you can see how much, just like a tumor flush, very massive increase in the circulation at this site, and that may be the cause of the increased venous return, and that may be the cause of the compensatory enlargement of the veins at this site. And despite the fact that there is a lot of deformity, usually you don't find trophic changes, and that may be because the blood supply is good and the nerve supply are intact in these patients. Secondary bacterial infection is very common. In the past, there was a big talk that secondary bacterial infection is rare because the fungus, they produce antibodies and antibacteria. However, Abdullah and his colleague in Rotterdam reported high incidence of secondary bacterial infection, and Staph aureus was the common organism isolated. Increased hyperthermia in the site of the mycetoma, again it is a common feature, even with a solid tumor without sinuses. This is a PhD thesis. Usually the appearance of the mycetoma is deceiving, and this is after surgical exploration. You can see how massive, and when you look, you find only few sinuses, and in fact it was a very massive intraosseous involvement. You can see in the X-ray here, tibia, the fibula, and the femur, and the MRI showed massive involvement in spite of the fact that there are very few sinuses seen, and that is why local anesthesia is contraindicated in these patients. Usually the mycetoma lesion, it is firm in consistency, fixed and skin line structure, but in some cases like this, we found them was very cystic. And when you open the cyst, you find full of fluid, and within the fluid there was a lot of grains floating there. And the fluid was examined. It was found to be an exudate with large amount of proteins and inflammatory cells. Interesting enough, in these cases, always you find one or two sinuses away from the cystic mass. We don't know the cause. Spontaneous regression in mycetoma, it is rare. Spontaneous healing, it is absolutely not reported as far as we know. And this is one of the cases where there is spontaneous regression. You can see a lot of fibrosis around the grains. Professor Hassan named them as albino grain because there is a lot of deficiency on the pigment of this with a long-standing problem. We don't know how these things happening. The clinical presentation in Sudan, as seen in other parts of the world, is the same, depending on the type of mycetoma, the size, the duration, and the immune status. Actinomycetoma is more aggressive, more destructive, more inflammatory, and affect the bone at an early stage. In contradistinction to eumycetoma, it is commonly localized because a lot of grains, a lot of capsules around it, less inflammatory, affect the bone at a later stage. This is a good in a way that localization of the infection, but the problem is penetration of the drugs. It can spread locally by the lymphatics, and you have proof now it can spread by the blood. Locally it can spread along the facial planes, and you can see how massive the grains in the surgical specimen like this. All the facial planes were studied with these grains. Interesting enough, in these cases, the tendons and the nerve are not affected. We don't know the cause. And then it can spread locally along the facial planes. This is a patient with massive mycetoma of the perineum, scrotal, and he came one day with a massive gluteal abscess. We saw this is a simple bacterial infection, and when we drained the abscess, we found a lot of grains. So that means that has spread along the facial planes to affect this part. With secondary you can see how massive the redness and the cellulitis around it. And this is secondary bacterial infection. This is a very interesting patient. Patient had an acute appendicitis. He underwent appendicectomy somewhere else, and he came a few weeks with a burst of the wound, secondary bacterial infection, and then they found that during the dressing black grains. And that was a big problem because surgeons always say that you are contaminating our theater and our ward. Lucky enough, we found that he has a mycetoma of the back. An MRI was done, and the MRI showed locally spread from the lesion in the back to the anterior abdominal wall, and he has a spread on this side. So again, that demonstrates that local infection locally spread can take place. How massive is it? It can spread by the lymphatics, and this is a very massive mycetoma of the foot, the dorsum and the plantar surface. He had along the saphenous vein, he had a massive secondaries there, and we saw that was a blood spread along the saphenous vein. Professor Hassan did a lot of sections of this specimen, and he found no affection of the saphenous vein. And in fact, that was a lymphatic spread. Another patient with massive actinomycetoma of the foot, and that was a spread along the lymphatics. He had the mid-tarsal amputation, Simon's amputation, and then he had a spread without evidence of that, and it settled in the inguinal region. We will see him on Monday, hopefully. And you can see how massive is it. This is simple lymphatic spread on this. By the blood, this is a patient of Mr. Arbab. He had a cranial nerve, a cranial involvement. He had an exploration, and they found within the blood vessels, in intact blood vessels, they found these grains. And this is definitely will tell us that the blood spread can take place. Another patient with a massive mycetoma of the spinal cord. He had a paraplegia. He had an exploration by Mr. Arbab, and within the histology specimen, we find a grain within the intact blood vessels here. And again, that was Streptomycin somaliensis, I think so. And you can see how intact the blood vessel, and the grains within the blood vessels here. And the skin over the back of that patient was absolutely normal. And even in exploration, nothing was found in the subcutaneous tissue. The only explanation, it may be a blood spread mycetoma infection. The lymph nodes are commonly involved, commonly enlarged in this patient. Secondary bacterial infection, immune response may be part of it, or it may be genuine spread from there to the inguinal lymph node. And even you can see the grains in the lymph nodes. And again, this is a well-known spread way for mycetoma infection. The site, literally every part of the body can be involved. The foot, 70% in the Sudan, and for unknown reason, the left foot, it is involved more than the right side. The hand, secondly affected, 8%. And then you can see in the groin either primary or secondary infection. This is the secondary lymphatic spread. This is the cranial nerve mycetoma. Interesting, the bone was involved on the outer side, and there is no intracranial spread of the infection. And you can see how massive on this side. She was completely cured. I will show the picture in a minute. This is the lateral view. And this is very interesting. The X-ray in patients with mycetoma of the skull is different from other parts of the body. Differential diagnosis may be multiple myeloma, may be other generalized condition of the bone, but commonly it is very osteoplastic. This is a patient with a mycetoma, the cranial mycetoma. You can see the eye changes, proptosis. CT scan showed the bone involvement. The patient was seen, he had a mycetoma. He had a very massive bilateral proptosis. He lost vision in one side. He lost hearing completely, and we lost him in the clinic. Probably he is not around with us nowadays. This is Professor Mr. Arbab patient. A very interesting case. He's going to present it tomorrow, but you can see the intracranial involvement. And I would like to say that this patient, his case is available at the e-learning center just around the corner. You can see the video clips, you can see the histology, and you can learn more about this patient. Eye mycetoma, it is not very common. We saw 2 cases. This is one of the cases. Professor Hassan last week, he saw the histology of this young chap, and that patient proved to have an mycetoma due to Madrella mycetomatous. He came with proptosis, secondary bacterial infection, intracranial spread, and he had a decompression on the side, and he's still under the care of the ophthalmologist. I am sure he'll be going to transfer to Mr. Arbab surely, and because he needs an intracranial intervention. Axilla, breast, axilla underside here. Sometimes you see cases like this. I will show you tomorrow some of the cases treated surgically. And this is the gluteal, scrotal, penile mycetoma. It can be, this is the scrotal mycetoma. Massive mycetoma, difficult to treat. It can be as massive like this. This is an mycetoma with massive bleeding at this side, not very common presentation. You can compare now the knee joint in both sides. The back. This is very interesting case. Twice reporting allowed. Unfortunately, he is not available now. He had a mycetoma of the back due to Escherichia podii, the pale green mycetoma. He was seen in the clinic there. He had a massive the back involvement. He had a multiple surgical excision. He had a very massive skin grafting at this side. And then he did not respond to any treatment. Itraconazole, ketoconazole, griseofulvin, nothing was helpful for him. Eventually, the patient developed massive vertebral column spread. He had developed massive paraplegia, and he died from severe uncontrolled diarrhea, part of his neurological problem at this site. Intra-abdominal mycetoma, it is not very common, very few report on that. And this is a patient came with multiple varicose veins, and that proved to be retroperitoneal actinomycetoma with complete block of the external system. And this is very interesting patient. She came with acute retention of urine. She had an actinomycetoma with a very bad circumcision. She developed massive acute retention of urine and massive hydroureters and hydronephrosis in both sides. She had a suprabig cystotomy, and she improved after that. Some patients, they come with multiple lesions like this. It can be as massive as this, or even massive like this. The foot, the side, the inguinal region, and the hand. Difficult to treat, and that was a patient with an mycetoma, not responding to antifungal treatments. This is an interesting patient. Patient came with tuberculosis and mycetoma, and actinomycetoma, sorry. He had a life-saving above knee amputation. He was toxic, secondary bacterial infection, not responding. The patient developed recurrence on the stomach. He had a very massive thigh involvement, and then he came with discharging sinuses in the anterior abdominal wall. CT scan showed that there's complete destruction of the architecture of the site. And one day he came to the clinic complaining of discharge of grains in the urine. The CT scan showed that there's involvement of the pelvic region, the bladder displaced on one side. Cystoscopy was done for that patient, and it showed a massive intravesical spread, and you can see this is the vesical floor inside. The mucosa is badly inflamed, and this is the mass on the lateral side pushed the bladder to this side. Differential diagnosis, as Professor Mahjoub always says, any mass like this should be considered as mycetoma until proof otherwise. Differential diagnosis can be a fibroma, neuroma, a chronic osteomyelitis. This is, in fact, it was not a megamelanoma. It is an mycetoma patient. Kaposi sarcoma, other problem, that is the keloid example, and other skin diseases. Diagnosis, a long list of investigation are required. Clinically, typical, radiology, soft tissue masses, some calcification, and the cavities are very pathognomonic of mycetoma. The small in size, it may be large in size, few in number, with good sclerosis with the mycetoma, whereas with the actinomycetoma they are numerous and you cannot count them, and very small in size. The skull, as I mentioned, it had a very distinct appearance. Pathological fracture are not very common in these patients, although the complete bone destruction like this, because the grains, the fibrous tissue, the granuloma give a support to the bone. We reported on 12 patients with pathological fractures in this patient. This is very interesting. This is an ultrasound of a patient with mycetoma. You can see the grains. You can see the grains floating. They are floating in the fluid at this site, well encapsulated. Cytology, tomorrow we're going to talk about this, but you can see the tissue reaction, type 1, type 2, type 3 tissue reaction. And you can see the grains, typical. This is pelletieri. You can see it under the microscope. The histology, Professor Hassan reported on 3 types of tissue reaction, type 1, type 2, type 3, the granuloma at this site, and we're going to talk about this in a minute. CT scan, MRI for tomorrow's discussion. Many patients present late. They present late because it is painless, slowly progressive, lack of health education, and they come with such complication like this. This is one of the patients just outside the clinic, start using a piece of glass to clean his wound. This is the piece of the glass. Health education is a big problem. Ladies can be affected, and this is a problem with the cosmosis. This is a big fibrous foot, not useful. And then even the surgery has problem. You have amputation, you have fibrosis, you have a stricture like this. Disease atrophy in a patient with this, a combination with poliomyelitis and a mycetoma. Difficult combination. All these patients, they need a support. 2 members of the family trying to support this lady. Always they need a support to climb stairs, to open a door. It is a big problem. This is always, you see always picture like this in the clinic. Not very much afforded this